Yeah, so I'm Talha Munir. I'm a hematology consultant from Leeds, and I've been working in treating CLL patients for a long time now. And a lot of my work is based on working with the novel agents that we all know about, such as BTK inhibitors, PI3 kinase inhibitors, and venetoclax-based therapy. And what we try to do in Leeds here is try to focus on what is the best way to take these drugs forward and to use in our patients, like the discussions we had that CLL is a very heterogeneous disease, and every patient is different. So a lot of the times what we are concentrating in UK, and I'm just talking about the trial specifics here, is that we want to construct the treatment design based on individuality for the patient. So if a patient is responding very well to therapy, we want to see what is the duration of treatment we need to give. And we briefly talked about minimal residual disease, and I can go into a bit more detail about that, but our main concept is individualizing therapy for individual CLL patient. And really, I think that's where my research focus goes further forward, and that's what we want to get forward with. Obviously, COVID has changed things, and a lot of things have changed for all of us. But I think there is still, we can quite sure, I can say safely that there is a light at the end of the tunnel, and actually, even we are seeing good data for immunocompetent people who've got good immune systems. But CLL patients are lagging a bit behind, but they're not far away. And I think we need to just make sure that when we drag us out of this pandemic, we are all in it together and try to get all our patients towards the road to recovery. And that's how I see it. Completely understand the anxiety that my patients have and CLL patients have. But at the end of the day, we are making progress, and that's the most important thing to recognize, in my view.
Okay, thank you for that. I mean, I understand that you were involved or are involved with the FLAIR trial. How's that progressing? I mean, is there an extension to the FLAIR trial, or?
Yes, FLAIR trial is the UK phase 3 trial, and the phase 3 trial means that we are comparing new therapies to the standard therapy and trying to find out if our new therapies are better as compared to the standard therapy. And the trial was conceived back in around 2013-14, and the problem we as clinicians have in CLL is that by the time we are going to report the trial, the new treatments have moved on so much that actually the standard of therapy has changed by then. So back in 2013-14, we still were dealing with chemoimmunotherapy, ibrutinib, and idelalisib were the drugs which were coming along. So the standard of therapy was chemoimmunotherapy, which was FCR-based therapy, and that's still stands true in a lot of countries in the world, that chemoimmunotherapy is still given as a first-line treatment. And we compared that with ibrutinib rituximab, which was the first part of the trial. And right in the midst of the trial, we found out that obviously other groups are looking at the same question, and ibrutinib was getting its license in US and in Europe and UK as well in the relapsed refractory settings, and venetoclax was starting to come along. And we did some early phase 2 studies, which were a small number of patients in the relapsed refractory CLL, and we saw very encouraging data. And I'm talking about Clarity study, where ibrutinib was combined with venetoclax, and what we saw in that study was that nearly half of the patients were achieving very deep MRD negative remissions, which means that I cannot pick out 1 in a 10,000 cell, which is a CLL cell. But then we went down a bit deeper into doing some clever tests in the lab to pick it out that we cannot pick those CLL cells in 1 in 100,000 cells. And now we have got a few more techniques on our hand, which we can go in 1 in a million now. So the tests are becoming quite sophisticated, and Clarity study told us that actually if we use this combination, we've got a group of patients who are going to do very well. And that concept, we took it forward into our phase 3 FLAIR study. And essentially, we jigged the design in such a way that FCR was still the standard of therapy, but then we combined with ibrutinib long-term therapy, but used ibrutinib and venetoclax, but that would be given based on how well the patients respond. So for giving you an example, that if a person had CLL and we gave ibrutinib and venetoclax for 12 months, and after 12 months, that person has achieved complete MRD negative remission and they have got no disease left to treat, they will get 12 more months of therapy and then they will stop at that point. Another person might be slightly different and they achieve the MRD negativity at 18 months of combination. And then we will use 18 more months of therapy for that patient to make sure that they go down very, very low level of disease, or in some patients, we would argue that they might have that reach that point that they might not need another therapy. That might be a small number of patients. And then there would be some patients who actually are not that sensitive to that combination. And in those patients, the ibrutinib will continue on long term so that they will achieve the benefit. So it's kind of an example of individualizing therapy. It might not be the best way to look at the answer because the heterogeneity, basically, I would argue, would depend upon the genetics of the leukemia. But it is, MRD gives us a very good focal point to tell us which are the patients who are going to do the best and which are the patients who might not do the best. So FLAIR is completed recruitment from that perspective. Now we have got an expansion, which is just looking at that difficult group of patients who've got abnormality in TP53 gene. And that is the cohort which is open at the moment, small number of patients, but we are using the same principle for those patients as well to give us some answers for future how to tackle the disease.
Okay, thank you. It's interesting you've mentioned FCR and you've mentioned the novel therapies that are coming along or are here now, I suppose, with ibrutinib, venetoclax, etc. I mean, why? Just quickly, why does it take so long? And given how quickly we managed to get the vaccine into production and into our arms, do you see this process now being sped up by the governments so that it doesn't take quite so long for these drugs to get into the marketplace for us?
Yeah, I think that's a very good point. But I think these drugs have found the way quickly, and especially US is a very good example where in the data from relapsed refractory CLL, these drugs got approvals very, very quickly because we didn't have anything at all at that point for our patients. But now I think the problem that new drugs will find, and I'm now talking about the second generation BTKI inhibitors like acalabrutinib has got its license now, but then there are other ones like zanubrutinib, and then Loxo 305 is coming, and there are a few others. The problem really is that these molecules, if I would have, a hand to use these molecules, I would offer it to my patients. But these companies have to prove that these drugs are better than the standard therapy. Now, if your standards are very high, so for example, I'll give you an example that the trial that was done to look at ibrutinib versus chlorambucil in first-line CLL. Now, chlorambucil, when we used to give it to the patient, half of the patients will need another therapy after 1.5 years. So your bar is set very low there, and ibrutinib clearly has beaten chlorambucil there. Now, if your bar is ibrutinib, and you look at the frontline data, your median PFS, which means half of the patients, when are they starting to relapse? For the frontline CLL, it's even at 7 or 8 years, it's not reached that point. So if you have got the standard, which is as good as that, then the new therapies will find it difficult to beat that standard. And you have to have that long-term follow-up data to give us the answer. And that's where innovation comes into play. That's where you have to have those trials which are able to give that answer quickly. And MRD is one of the ways by which you can have a very short-term endpoint to look at the question. But like Brian said, ibrutinib, there is no question that MRD should be the question there. But with venetoclax-based therapies, that is the main question. That if we achieve MRD negativity very quickly, we stop therapy quickly, are these patients going to have the same PFS as the patients who have continuous therapy? And that is where statisticians and people like us have to design the trials in such a way that we get an answer quickly. And then it's up to FDA and EMA to recognize that this is a problem. And we need to recognize these alternative ways rather than our old ways of analyzing data, which will take years for us to develop. And, I might not be able to, give those answers during my career. It's as long as that. So you need to find innovative ways. And I think that's where we're heading towards. And we had some discussions with FDA and EMA regarding all of those points. And I think they have got some reservations, but they do understand this point. And I think vocally, yes, clinicians make a difference, but I think the patient's voice is the strongest voice actually in this, in all of this issue.
And do you think we're, as CLL Support, as CLL Ireland, and the other various charities that are out there supporting CLL patients, do you think we're shouting loud enough? Can we do more, do different? What do you need as a consultant? What would you like to see us doing?
Yeah, I think, yes, it is understanding that point really, which we need to convey to the regulatory authorities, which is very important. So, for example, this when I spoke to FDA and we had a good meeting with other colleagues from states talking about these things, I think their main concerns were about, they understood the point, the main concern was around how you will make the data, which is there is no inter-lab variability. So their main issue was around the laboratories being able to give us the right answer, like what Michael was saying, Brian was saying, that you don't have MRD analysis throughout Europe. There are some countries which are still lagging behind. So their concerns were around those areas, and that could be, solved by doing central analysis and all of those kind of things, which is, there are ways around that. But at the end of the day, if they don't recognize MRD as an endpoint for a trial, if I'm doing a trial where MRD is an endpoint, but FDA doesn't recognize it, then it's not going to approve the drug. And that is where, the problem lies. And it's our job to convince them scientifically that this is the right rationale to do it. But then I think if the patient understand what MRD stands for and the support groups understand that this is an important endpoint to look at, as well as other endpoints, then that could be, we could lobby for that, and kind of, the seminars that FDA and EMA conducts with patient groups as well as clinicians make a very strong case for these kind of things.
Okay, thanks. Is there from your perspective, is there a strong pipeline for, Brian referred to it briefly in his talk, but is there a strong pipeline, do you think, for treatments?
Yes, I think we are, the pipelines are coming along at the moment, but I think it is fair to say that a lot of the molecules that we used in the relapse refractory setting are moving to the frontline setting now.
Right.
And the issue that I find it difficult now is that relapse refractory space is a bit empty at the moment, and all we are seeing is some new BTKI inhibitor like Loxo is very good, and there's another one called ARC-531, and these molecules will find their way, but what the companies will try to do is to move to frontline setting because that's where they want to use it. But these molecules might take away the benefits we are used to be seeing with ibrutinib or acalabrutinib, and we have one drug short in the relapse refractory space. But that doesn't mean to say that we shouldn't be using these molecules in the frontline setting. What I'm just trying to say is that these molecules should be used in a way that is of most benefit to our patients, and then we are able to, find out about them, how these molecules will behave in different settings in the right way. The CAR T cells are very interesting. The only problem we've got with the lyso-cell and everything is the tolerability still is an issue. But there are data from CAR NK cells, which are very interesting cells, which are very different to T cells. And we can talk about it in a bit more, but this is an over-the-shelf product which is taken from the cord. And that appears to be showing some very early good data, really phase 1 data, but that all kind of swept on the carpet really because of the COVID. So we have got lots of things coming along, and the CLL is kind of going through a same phase, which is there's another disease called chronic myeloid leukemia, which there was nothing till 1998, and there was then a tyrosine kinase inhibitor called imatinib came into play. And then we had a number of drugs coming in the next decade, and then everything dried up, basically. And now if you look at the CML trials, they're looking at very, very small questions. We don't want that to happen with CLL. CLL is very different disease to CML, everything. I think what we need to make sure that pharma stays interested in CLL. And again, that is, very important, because we still have difficult patients like relapsing on multiple molecules, and also to avoid complications like Richter's transformation and those kind of things. So I think it's this space in the relapse refractory setting needs to have a bit more going on. And I'm pretty sure there are multiple new molecules coming. The problem really, which the companies find it difficult to say, is that it's such a crowded market now at the moment. How are we going to develop our molecule? We have to put an investment of so many dollars into making a drug which might not reach approval at the end. And I think it is still for us to convince them that it is worth doing that, because still we are not there with the stuff that we've got at this moment in time.
I know, speaking personally, I'm tremendously encouraged by the therapies that are there and the therapies that appear to be in the pipeline at the moment. Do you think the combination therapies like venetoclax, obinutuzumab, these sorts of things are the way we're going to be going in the future? It won't just be one molecule. It's going to be, you're going to look at me and say, you need this combination, Lewis,
Yes, and I think that's where we're heading towards anyway at the moment. A lot of the frontline trials are looking at that combination, whether we use a doublet or a triplet, and which is the safest option for all our patients, really. So what we try to do is to debulk the disease very, very quickly, try to get patients into very, very deep remission. All the combinations at the moment, like venetoclax with obinutuzumab, fantastic data, 12 months of therapy for everybody. I would just argue that patients who are still not got their disease completely cleared away after a year of treatment, those patients are going to relapse quickly. And in those patients, it's difficult to see whether they would respond to venetoclax again, but that's one drug out of the way for them. And that's the difficult bit that I find. So in my view, the MRD-driven approach allows us to identify those patients who could still benefit from continuous therapy, rather than we just making a distinction. Are you going to have just, defined therapy of 12 months, or are you going to get continuous therapy? I think it's a combination of both, and we have to kind of find the ways how we will identify our patients to be using these drugs in the best way possible.
Just briefly, you mentioned a few minutes ago Richter's transformation. Mm-hmm. I don't want to dwell on it, but do you know if any work being done on this area?
I think that's one of the dreaded complications that majority of the CLL experts find it difficult to how to manage it. But I think one of the things that I would say is that if you treat the CLL up front with the best treatment possible that you can give to the patient, then Richter's become less of a problem. But it is fair to say that once patients get Richter's transformation, our options are very limited. Majority of the patients have got complex genetic changes, and treatments like chemoimmunotherapy, which is the way we go towards that disease, doesn't really give a long-lasting response. And all the trials have shown that. Where we are interested now is that these molecules like the BTK inhibitors, the venetoclax-based therapy, in combination with chemoimmunotherapy or in combination with CAR T cells, actually are the right way to go. And there are, for example, in UK, we can use CAR T cells for Richter's patients. Now, there is not much data on that, but at the end of the day, we are going to collect that data for our patients in UK, and it might be that that's exactly the right approach to take for our patients. So there are different things that are being done. There are, I know, the bispecific antibodies, they are coming for Richter's transformation, and some of the companies like Regeneron and Roche and their products are already being trialed in very early stage. So I think if somebody's unfortunate enough to get Richter's, it's very important for the clinician to look around to see which is the best treatment option available around the country. And there are trials around which I would really urge people to go on to, so that we get the best data out for patients and see which is the best and the right approach for treating patients with Richter's.
As I say, I do find, what's happening and coming down the pipe very encouraging. We made a video with one of our fellow trustees, John Greensmith, who was diagnosed, I think, in his mid-30s, and he must be nearly as old as I am now. So you get the idea that, as he's progressed from one treatment to the next treatment to the next treatment, but for the younger patients, it's good to see that there is a path, a pipeline, if that's the word you want to use, good marketing term, pipeline for these treatments coming down. What do you think, if for the, I don't know how many of the patients are younger in those terms, but what would you say to them at this stage?
So I do worry about the young patients, Lewis, and I think the problem is that there's data that 10% of CLL patients are below the age of 55, and that is 5% are less than the age of 40. So, if you look at when I talk to a younger patient, my discussion right at the beginning is quite intense with them, because obviously those young patients are worried. They are worried about their families. Fertility is an issue. If you are going to use chemoimmunotherapy, we are also going to be talking about different molecules which are being licensed at the moment, and there is no data whether these molecules would be safe in pregnancy and those kind of things. We don't have any data on that. And I do talk to the patients about, using the therapy when it is absolutely essential. One of the questions, so for example, I had a discussion just recently where nodes were becoming more prominent, and if I was the patient, I would say, treat me because it is annoying for me. But apart from that, I'm okay. And I really gave that sense of, the story that I want to tell, that, if I give you chemoimmunotherapy, I might give you 4.5 years. Ibrutinib, I might give you 5 years. Venetoclax, another few years, that kind of thing. If I use trials, I might extend that. But at the end of the day, where I'm sitting now, my options will stop at that point. And I don't want to be telling you now that this is what it is going to be the end of the road for you. So, and then, I do talk about allogeneic stem cell transplant to my patients. I do talk about CAR T cells. So I give them a whole journey of what is available now at this moment in time, with a caveat that actually this might change and I might have other options for you, but that I cannot tell you at this moment in time. And most of the times, patients, if you have that kind of a discussion, then you have what Brian and Michael were saying, an informed decision. And that is the most important thing, because I should not be making that decision for my patient. It's the patient who should be given the full information, and they have to then take this journey alongside us, which I can only help with that journey. But I want to give the maximum information that's out there to my patient.
I think one of the things that was mentioned again earlier in discussion was the fact that, a lot of GPs really have little experience of CLL. And if they've ever seen it before. And the question becomes, how do we as patients, as charities, move them forward, help the GP, our GP, to understand what we're facing and what the options are. And it's that whole discussion. So, having a good discussion with your GP has got to be a good start, as well as your consultant and whoever else will listen to you has got to be a good starting point, I think.
I think that's very important, Lewis. And I think that's the first thing that the first time I see a CLL patient that's the maximum amount of time that I give for a CLL consultation, because at that point I need to convey the message that you must probably going to go on to watch and wait, but there is, or people use the word watch and worry, but you need to remember the risk of infection that CLL patient will have. You need to remember the autoimmune complications, and that needs to be kind of filtered through to the GP as well, so that they are aware of that, because 9 out of 10 infections I'm not going to see. It's the communication between the patients and the GP which is going to be very important. And what I do normally is enlighten the GP about the risk of infections, pneumococcal infections, encapsulated organisms, risk of shingles for my patients, as well as obviously with the COVID being there, all of those risks. And I do check the antibodies against common bugs that we should be doing in our CLL patients. And I tell my CLL patients that after the bone marrow transplant patients, you are the most vulnerable patients that we see hematologically, because the immune system is suppressed both in terms of the B and T cells. And if any patients who get more infections is the CLL patients. And so they need to be aware of that. They don't need to stop living their lives, but they need to be aware of that if they get an infection, they should see their GPs or see us sooner rather than later. So that is a kind of a discussion that you need to have right up front and try to convey that message to the GP. And I agree with you, Lewis, that some GPs will be interested, whereas other GPs won't be interested at all, and they will just leave it to us. But we try to inform the GPs as much as we can do, and we do some focus groups with GPs as well, trying to give them some facts and figures so that they can understand.
Yeah, thank you. One of the things that we've found, CLL Support have found, we have a bit of self-publication here, not self-publication, but CLL Support publication. We have a booklet and very comprehensive information about CLL progression, that kind of thing. And we have found that by giving this to the GP, it might surprise them, but actually there's a lot of information in there that helps you as a patient, or one as a patient, to communicate with their GP, even their consultant sometimes, to say, hey, look, this is what we're being told, this is the information that's out there. And I've personally found that has helped me to reestablish a better level of communication, let me say, with my GP. So, the information's there, you can download it from the websites, we can send you a booklet, but you've got to use it as well.
That's very true. And I think and also, being informed about the risks that patients with CLL have. Majority, 30% of CLL patients may not need any therapy in their life at all. That is true. That figure still stands true. So watch and wait and watch and worry is still the right thing. But even those 30% of people will get complications which will be related to CLL. So for example, infections, for example, people get frequent skin cancers, the risk of other secondary cancers are slightly high. So essentially that risk still is there, and one needs to be aware of that. And, those kind of discussions, like through this support group, is very, very important.